Okay, so today we are going to discuss a policy by Peace Health St. Joseph Hospital on seclusion and restraint and how to better the situations that this policy pertains to, particularly in behavioral health unit, also known as One Central. Our objectives are that by the end of this presentation, the listener will identify the major reasons why debriefing after a seclusion or restraint episode is beneficial. The listener will understand the complications that behavioral health units face among patients and staff interactions. The listener will be familiar with the reasons why behavioral health nurses experience burnout. The listener will understand the recommendations for updating the policy as it pertains to Peace Health policy on seclusion and restraint. An overview of our presentation is that the next part of this, I want to show a video that depicts what a possible situation could look like that requires restraints and seclusion. This will hopefully introduce you to the atmosphere of a behavioral health unit and help everyone to understand what a behavioral health nurse goes through in order to keep the patient safe from harming themselves as well as other patients and staff. I then will tell you a story about what I experienced while precepting in One Central. Okay, so my story goes that I was sitting at the nurse's station charting. I heard a patient screaming at the behavioral health counselor and the psychologist. The patient comes out of the room and continues to scream. The psychologist left the area because she said that she felt the patient was getting more upset by having her there. The patient sees that there is a commotion going on and throws a chair down the hall multiple times. She bangs her head into the wall, and I finally call security, and then it quickly becomes a code gray. I watch as the patient is kept behind a closed door until more staff can arrive. The patient is then helped into her room by the arms. and the patient finally gives up and lays on the bed as restraints are applied, and the behavioral health counselor sits outside the locked door monitoring the patient. The patient continues to scream for a while, and then finally lets out after a while, or about an hour or so. She's medicated and a lot calmer. At this point, everyone on staff gathers to debrief. That takes about 1 minute and consisted of, is anybody hurt? Does anything need to change? Then the head RN leads the code, finishing the report, and everyone leaves. My insight into this is that there needs to be more debriefing that needs to take place, and I will later on tell you why. This topic is important because the human significance is that staff nurses working on the behavioral health unit need to protect themselves. The PCL policy has sections written about when, where, and how to legally put a patient in restraints, and that the way to explain before, during, and after when the patient can have them removed, and under what behavioral circumstances the situation warrants an application. This does legally protect the nurse, but what about emotionally? Who is really there for the RN? And the real question is that, and we need to figure that out in the future for our nursing. This policy is needed, as I already mentioned, to protect the safety of the patient because of previous abuse inflicted on the patients in the past who were in mental hospitals. It is what horror movies and every paranormal TV show talks about, and we cannot have that continue to happen. But nurses are put under massive amounts of stress. I have heard some nurses state, I feel more like a babysitter than a nurse sometimes. Research shows that nurses who have no one to talk to experience negative consequences physically and mentally, much like the patients they take care of. This will improve outcomes by increasing the nurses' retention rate. Nurses who feel supported will not burn out as easily. Patients will experience a calmer environment, the atmosphere of the unit changes how patients behave, and if the staff are on edge, patients pick up on that, especially the anxious ones who have a tendency to excite everyone else on the unit. The briefing will allow nurses to learn from one another. When this happens, new lessons and methods are taught to de-escalate patients. This will lower restraint seclusion rates because patients will be taught coping techniques instead of chair throwing and head banging, as in my story. This policy was reviewed in October 19, 2015. It's up for review again in 2017. So this is a pretty current policy, and I think the policy is well written and the information is up to date. But debriefing and education among staff needs to be written out on the policy to remind everyone who reads it what the steps are that I propose are written to inform staff on how to debrief everyone. So this is the first page of the policy that I chose, and I only showed the first page because it shows that when the policy was updated and when its next review is. But the part of the presentation that I am talking about, the policy isn't actually written for that yet. So it is a 17-page document, and at the end of this presentation, if you'd like, you can zoom in a little bit and look at this, and I also included the link to it so that it can be looked up at the hospital. But there isn't a whole lot of reason to show more than the first page, since what I'm changing isn't included. And this is the poster. So here the poster, I included the changes that I would make and that I will talk to you about in a bit, and the reasoning behind debriefing the staff. So my PICO question is, the population was one central. The issue of interest is that there is a lack of debriefing of staff and it affects behaviors and outcomes of patients. The comparison of interventions is that there are a lot of debriefing that seems to go on for the patient, yet there is none for staff, and that's not helping when only one group is talked to when both can have an effect on the other. And the outcomes and time frame are not applicable to this present situation, so I didn't include them. The first article that I thought supported what I was talking about in the policy is by Huff and Adams. It was a study done in a hospital in Rio de Janeiro investigating that placing a patient in seclusion over restraint does not increase the likelihood that the patient will remain in the hospital for longer periods of time. A pilot study was ran in 2007 with 10 patients, and then later in 2010 with 105 patients. The study was randomized, and half of the patients were placed in seclusion, and the other half were placed in restraints during an outburst on the unit. The conclusion of the study shown that while it is not an exact science, Placing a person in seclusion over restraints was more often than not enough to de-escalate the person so that medications could be given and discussion could happen between staff and patient. The second article that I discussed was from Chandler in 2012, and the study discusses how the environment of a behavioral health unit can change the use of restraints and seclusion to almost non-existent. The author interviewed a 20-page inpatient unit in a hospital in England and found that when the staff are empowered and tools for recovery-based care are implemented, there are fewer instances of escalations among patients that require seclusion and restraint. The change in how staff thought about their patients was, according to the author, a major contributor to the success of the study and what made the unit stand out from others among the English hospitals. Another study was by, I'm not going to even try to pronounce his name, but you can see on the screen. A study was done in the psychiatric unit in Melbourne, Australia, and it focused on 39 nurses who felt that they were not being properly educated on the use of restraints and methods to de-escalate patients before behaviors got out of control. Many of the nurses in the study claimed to use restraints as a way to protect themselves and other patients, while others used seclusion as a timeout for patients who were overstimulated. The study went on, and more of the nurses admitted that they felt with adequate staffing that the unit could be improved upon, as well as mini screening of the patients to see how appropriate they are for the unit instead of allowing patients with a higher acuity to be admitted only to have less than ideal outcomes. The study allows the nurses to talk freely in hopes of improvement across the board for inpatient mental health units. A fourth study was Patterson in 2012. The study was in England and explained how restraints and seclusion are overused by staff and how the outcomes of these episodes could have been eliminated by teaching the staff about techniques of de-escalation and supporting the nurses through the hard moments. When the nurses were putting these patients in restraints and keeping them in rooms alone, it was bringing back past traumas and abuse to the patients, and it had an opposite effect, and it was hurting the patients. Nurses then were not able to develop therapeutic relationships and were doing only what they had to do. The solution is training and recovery-based approach to all that the nurses do. So, the impact on nursing is that this change affects the nurses, and it keeps the patients and staff safe, and debriefing allows staff to express feelings. It allows for reflection and change among units. It creates a sense of team. It prepares staff and inherently calms patients when staff is not uptight. It also allows for a chance for staff to learn through mistakes. The biggest implication is that it allows for a higher level of nursing retention rate and less turnover on the unit, and that is better for the patients because then they are not having to learn to deal with new nurses, and it takes a while for a person, especially in behavioral health, to start to trust a nurse and start to know their name, and once they do, things usually get a little better, but beforehand it's hard to try to deal with having a new nurse on the unit and having patients who don't want anything to do with them. So, I propose to change the policy and update it so that at the end of the document there is a list of how to debrief the staff so that each person does it the same way each time, no matter who leads the code. This includes a group discussion, asking if the staff feels they did their best, what went well, and what could be done differently to improve the outcomes. Were there injuries, and did we do everything through the proper channels to report this? What triggers could have been avoided to maybe not have this happen, like what happened during the time when the patients were upset? Was something going on that the nurses didn't realize was going on, or a behavior they were doing themselves that escalated the patient? And what are some suggestions for future events, and does anyone have any extra need to talk to someone about what happened and maybe go through it a little more and have a little more extensive process? And I also feel that there should be a monthly meeting for all of the managers on the different floors to discuss the rates of seclusion and restraint so that other units can learn from one another and grow as an entire hospital. Because I feel like sometimes the different units on the floor do their own thing, and then later on they aren't really connecting with each other. I mean, there could be people in one central that maybe could have helped someone in the ICU with a situation, and they're not communicating. So it's a breakdown in the communication at the hospital. And I also feel that there should be monthly mock code grays for all units, not just one central, but especially there because it tends to happen the most. And there should also be this should also be written in the policy, but also as a separate document, because we don't like to repeat information, but in this case I feel it's very important to have included it in the policy itself, so if one or the other is found, it's easier to actually deal with and know what to do. So, in conclusion, I hope that you learned something, and here are our outcomes again that we can review to see if we met them through this presentation. So, the listener will identify the major reasons why debriefing after a seclusion or restraint episode is beneficial, and this is to help the staff reflect and help staff learn how to handle these kinds of situations when they come up. Number 2, the listener will understand the complications that behavioral health units face among patients and staff interactions. Stress among both sides makes it pretty difficult to communicate properly, and the rapport never develops, so healing among patients never happens, and this is a huge part of behavioral health and very important to understand. 3, the listener will be familiar with the reasons why behavioral health nurses experience burnout. Stress is a big one. Being understaffed is another. A third is that nurses feel they do not have support, so they keep it in until it becomes too much, and then that can lead to nurses leaving the floor, going to another unit, not being nurses anymore. It just becomes too much. And this can happen on any unit, but with the added stress of the behavioral health aspect, it tends to make it an even bigger deal, especially when there's no one to talk to with HIPAA violations. You can't really go home and talk to your family or your friends about it. So it's kind of hard when nobody else is listening and there's no actual set place to discuss what's going on. And number 4, the listener will understand the recommendations for updating the policy as it pertains to Peace Health policy on seclusion and restraint. So the biggest thing about this that I can think is that debriefing and listening to each other will make all the difference. Sometimes even just discussing it in a group for just a few minutes can sometimes just help tremendously with just getting it out there and saying how you feel and being honest, and that can really help. So these are my references, and I included, like I mentioned before, the policy number in case anybody wants to look it up for themselves, since this can happen in a unit at any time, so it is right there. And so I hope that you learned something today. Thank you.